Dr. Bell will provide us today with an introduction to palliative care for individuals living with neuroendocrine tumor. We really welcome and look forward to her remarks. Dr. Bell is an assistant professor at UCSF with training in internal medicine, palliative care, and integrative medicine. And she has joint appointments in the Division of Palliative Medicine and Hospital Medicine at UCSF. She graduated college at Wesleyan University, then went on to medical school at the Icahn School of Medicine, Mount Sinai in New York, did her residency at Mass General prior to her fellowships and appointments at UCSF. I've had the privilege of being Dr. Bell's colleague in supporting patients with the symptom management service at UCSF, and I most value her very keen listening ear and warm heart. So I'm looking forward to Dr. Bell's comments. Thank you.
Absolutely. Thank you all for having me today. It's a delight to be here. And I'm really looking forward to our discussion. So I will go ahead and get my slides pulled up and share my screen momentarily. It looks like, Josh, several people have entered the waiting room, and I know I'm a co-host now, but I'll probably go ahead and defer to you on managing that, if that's okay. Can everyone see my slides? Lacey, I can see your screen, so if you could just give me a thumbs up if you can see me and hear me okay? Okay, fantastic. The era of Zoom presentations is always a little bit unsatisfying, I must say. So thank you for, oops, sorry, I'm having a little bit of a technical issue here. Okay, fantastic. Thank you for having me, and thank you for that great introduction, Lacey. It's always a privilege to work with you, and it's wonderful to be here today to talk with you about how I think about palliative care for patients who are living with neuroendocrine tumors. And this is really meant to be an informal discussion and conversation. And so I would invite anyone who has questions or comments as we go along to please just feel free to speak up, because I won't be able to see everyone on video as I'm talking. And I hope that there will be ample time for discussion. My goal is really just to provide an overview of what it is that we do and what we might be able to contribute to your lived experience as you're living your life with neuroendocrine disease. And so with that, we'll move forward. I don't have any conflicts of interest to disclose. So there are three topics I'm hoping to briefly touch on today. One is just an introduction to what is symptom management and palliative care, and how that might be relevant to your life experience. Two, we'll talk briefly about symptom management considerations that might be applicable specifically to individuals with neuroendocrine disease. And we'll touch a little bit on advanced care planning as well. Before we dive into the didactic portion of the discussion, I wanted to give an opportunity, as Josh mentioned, to have some informal discussion in breakout rooms. And I've included a couple of prompts here. These aren't mandatory to cover in the breakout rooms. You'll have about 5 minutes to discuss with each other kind of what any of these topics, but it also could be very loosely related to these questions. So things I was interested in having you think about and explore with each other is what comes to mind when you hear the phrase palliative care. What NET related symptoms do you find most bothersome and would like help with? And also, what specific questions would you like to cover today as you think about this topic? I'll share my screen so that we can move on, and we'll make sure to have plenty of time for discussion after the slides as well. And again, for those who joined us a little bit late, this is really meant to be an informal discussion. So if y'all have questions or comments as I'm going along, like, please just feel free to speak up, as I won't be able to see everybody's screen. So a couple of the themes that I heard from you all is, one, I think one of the things that makes NET such an unique experience, and again, I'm speaking obviously as someone who is not personally impacted by it, but what I've learned from my patients and my colleagues and from speaking with you is that, it can be a very chronic condition that you live very well with for a long time. And it can feel like palliative care isn't always relevant to what you're going through. And certainly that sometimes is true. And also, I hope that I'll give you a sense of how our services can help be an extra layer of support for you and accompanying you on your journey, even during times where you are doing well. And we can talk a bit about what to maybe expect at the end of life, although I do think that that can be quite variable depending on what your experience is and the anatomic location of your disease, as well as your treatment history. So I think difficult to give a really uniform answer to that. And I would welcome Josh and Lacey's input on that as well as other members of the group who have had more personal experience with it. And we can also talk about preparation and recovery from procedures as well. So there's several different definitions of what palliative medicine is, and I've included a couple of them here for your review later. I think in the interest of time, I want to just skip ahead and give you a kind of overview of what it is that I tell my patients when we talk about what is palliative medicine and palliative care. So what I say is that palliative care is an interdisciplinary medical specialty focused on quality of life for individuals and their loved ones who are dealing with serious illness. And really what that means is that we're here to help you live as well as possible for as long as possible. And that can take a lot of different forms depending on what it is that you're going through and what your specific needs are, which certainly are dynamic and evolve over time, as many of you have already noted. When we talk about quality of life, I really think about that as falling into sort of two major buckets. First, there's, relieving symptoms related to burden of disease, as well as the therapies that you're going through. And here's a few examples. We have specific expertise in managing pain, nausea, fatigue, changes in bowels, including diarrhea and constipation, mood distress that can come up as you're dealing with serious illness, just to name a few. And this is by no means an exhaustive list. And then in addition to that, one of the ways that our team can help serve you and your loved ones is by making sure that the care you're receiving is really aligned with your values and your goals as you're proceeding through your life. And those evolve and change over time. And this can look like supporting you and making sure that you're articulating your views to your loved ones and your care teams, advocating for you with the rest of your care team to make sure that you're getting appropriate treatment that's aligned with what you need at this point in your life, and helping you with advanced care planning. And that's something we'll talk a little bit more about in a few minutes. One of the things that's really central to the way that palliative care is provided is that it's an interdisciplinary, holistic approach to care. And I want to just give sort of a visual representation of what I mean by that. And essentially what I'm saying is that the patient and their loved ones are always at the center of an interdisciplinary team that's working closely together to help optimize your quality of life and life experience. And so that team can consist of a few different players, most notably kind of a primary provider, such as a physician or a nurse practitioner, who works really closely in concert with non-physician providers, including our nursing team, our social workers. Lacey's been a huge asset and wonderful colleague to me in caring for our mutual patients over many years at UCSF at this point, as well as other providers, including chaplains who are closely involved with our work. And again, this list isn't exhaustive, but it gives you a sense that we all kind of work together to try to provide holistic care for you in this realm. And this interdisciplinary team really focuses on all of the realms that I was just talking about: symptom management, quality of life, advanced care planning, spiritual support. We often partner with our mental health colleagues to help provide psychological support and counseling when that would be needed, as well as financial and social support. I think it's important to note that palliative care is often thought of as something that just occurs at the end of life. And increasingly, our goal as specialists in this arena is to help us move away from this understanding of what palliative care is. And I'll talk more about end-of-life care in a moment, but it's important to note that this model of palliative care that I'm presenting here is really thought to be sort of the most up-to-date model of what it is that we do. And the main takeaway is that we deliver palliative care concurrently, meaning at the same time as you're receiving disease-directed therapy. And in many cases, that therapeutic intent may be curative, meaning that we expect you to fully get better from your illness or be able to live without a significant disease burden for many, many years and live well. But ideally, we really want to be, let me see, I just want a laser pointer here, bringing in palliative care at the time of diagnosis to make sure that you are feeling well, both physically, but also emotionally, psychologically, spiritually, socially, as you're navigating the initial period of time of your illness, and everything that that entails, including the uncertainty and all the life changes that it brings about, as well as the specific therapies that are involved and side effects that can often happen from those treatments. And then over time, particularly if there is an incurable illness that progresses in severity, palliative care kind of increasingly becomes a more dominant part of your treatment experience as we shift away from disease-directed therapies. And of course, towards the end of life, the most intensive component of care is often palliative care. And get rid of this laser pointer here, excuse me. Again, this is just another slide that goes into a bit more detail on sort of what is the differences between palliative care and hospice care, and what are the shared features between them. So just to quickly touch on this for your later reference, palliative care is really appropriate for any individual who's living with a serious illness. And those individuals may be seeking curative treatment for their disease, and this specialty service is covered by most insurance plans. Hospice care, by contrast, is sort of a smaller subset of what it is that we do that is appropriate for individuals who have advanced illness with a limited life expectancy and who are ready to shift the focus of their care away from disease-directed therapy towards an intensive focus on comfort. Typically, individuals get referred to hospice when they're no longer receiving disease-directed treatment and when their medical team suspects or wouldn't be surprised if they had a prognosis of 6 months or less. Although it's important to point out that people do, survive longer than 6 months on hospice quite frequently. Hospice is a Medicare benefit, and it's also covered by most private insurance. So typically this service is provided at no cost to patients, with options to kind of increase services for added cost. There's a lot of shared features, including expert pain and symptom management, focus on optimizing quality of life, regardless of circumstance, an interdisciplinary team-based approach like I showed you, and a care philosophy that really emphasizes the lived experience of our patients and their loved ones. So why should we consider early palliative care in the setting of serious illness? And, the short answer is that there's really abundant evidence for benefit. And I've cited several studies here that you can look at if you'd like to. Palliative care is associated with improved patient and caregiver satisfaction, reduction in symptom burden, increased efficiency and reduced cost of medical care, and in some cases, prolonged survival. And there was this one clinical trial that I'll show you. There are others, but this one is very famous. It's called the TEML study. and it was completed at Mass General in Boston. It was 151 patients who had stage 4 non-small cell lung cancer. So again, not NET, unfortunately. And they found that when palliative care was implemented early on in the course of this illness, it was associated with better quality of life, less depression, less chemo in the last 2 weeks of life, fewer hospitalizations in the last month of life, and actually prolonged survival. And that's what this graph shows. It demonstrates that individuals who had early palliative care compared to just standard oncologic care lived almost 3 months longer than those who did not. Now, I will point out that we haven't shown survival benefit in every single palliative care clinical trial. And also, that's not necessarily always the primary focus of our work, but it is important to note that that does sometimes happen. There have been other studies that have shown that early palliative care involvement is associated with several improved end-of-life quality metrics. And Carolyn, this kind of highlights a little bit some of the questions that you were asking about what to expect at the end in the setting of NET, and we will talk more about that. For individuals who had early palliative care involvement in this study, there was significantly fewer visits to the ER in the final month of life, much less ICU stays in the final month of life, kind of fewer incidences, or excuse me, lower incidence of death within 3 days of hospital discharge, lower incidence of dying in the hospital, and a decreased 30-day rate of overall death as well. I want to shift gears now and talk a little bit about how symptom management may be kind of specifically targeted for patients with NET. And certainly this is not kind of exhaustive by any means. These are just a couple of examples. And I think we can touch on the question that was raised about preparation for procedures and how we can be involved in that as well, and recovery in particular. So diarrhea and just bowel disruption more broadly is a symptom that I often am navigating in my patients who have particularly intestinal NET. Of course, it can often be related to active disease, but there are a subset of patients who continue to have significant symptoms despite disease that is in remission. And a lot of times this can be related to prior treatments. Surgical therapy, radiation, embolization are examples. Many of my patients have significant anatomic changes, and they really have to live with this, for the rest of their lives, even if their disease burden is quite stable and well controlled. There are other potential diagnoses that I always explore with my patients when they come to me with bowel disruption. And I've included some examples here, so it wouldn't be unusual for me to work them up for infectious causes of diarrhea, pancreatic insufficiency, and kind of disruption to the gut microbiome. And I given my integrative medicine background as well, that is a lot of the work that I do with my patients. And thinking through that differential, these are the typical diagnostic tests that I might do with patients to try to get at what is really going on when someone has chronic diarrhea, particularly when their disease is well controlled and we don't think that it's related to active disease. I will just say, certainly if there is active ongoing disease, the first priority, as I've highlighted here, is to treat the disease with octreotide or another therapy as recommended by your oncology team. And so, of course, we closely partner with oncology to make sure that we're all on the same page about what's going on and for the interdisciplinary care plan. It wouldn't be unusual for me to assist with treating a GI infection that can come up. Certainly, we do sometimes use the more traditional antidiarrheal agents that I've outlined here, and that acronym stands for tincture of opium. Dietary modifications can also be incredibly helpful for managing both diarrhea and constipation, and I work a lot with my patients around diet and nutrition. And also, it's pretty common to utilize digestive enzyme support and gut microbiome support, including specific probiotics. And I'm just checking the chat, and it looks like Barbara said, does anyone else suffer from ascites? And we can turn that over to the group in a few minutes when we have some open discussion. So I want to speak briefly about pain as well, because this is something that comes up quite often, both for my patients who have active ongoing disease, particularly in the peri-procedural period. I believe it was Joe who asked that question. So one of the ways that we can be most helpful in that particular time period is educating patients around what they might expect peri-procedurally, and oftentimes patients do have pain. It's also a time where there's a heightened risk of bleeding, and so we monitor closely to make sure that there aren't any kind of catastrophic complications of the procedure, and that's something that palliative care can partner with the rest of your oncology and interventional radiology team to make sure that we are monitoring for that. But it wouldn't be unusual to have to manage pain in the peri-procedural setting and sometimes in the chronic setting as well. And again, that can be due to active disease, and oftentimes in the setting of NET, particularly intestinal NET, that is due to anatomic changes and treatment-related changes that can result in chronic abdominal pain. So there's many things that we can do. Certainly there's a diagnostic workup involved, as I've outlined here. As far as the biomedical or Western medicine treatments for pain, that's an area where we have a lot of expertise, and we can utilize kind of a wide range of both non-opioid and opioid pain medications. And in the vast majority of cases, we are really able to help our patients be comfortable and have more freedom from their illness on a day-to-day basis. There's also a lot of data for kind of integrative therapies for cancer pain. And it's quite typical for me to refer patients for acupuncture, to talk about safe and appropriate use of cannabis for pain, to consider manual therapies, including massage and use of heat packs, particularly when there's anatomic changes from multiple surgeries that are contributing to chronic pain. And certainly topical cannabis and topical lidocaine are other treatments that I utilize regularly as well. One other symptom that tends to come up quite often for my patients with NET is fatigue. And again, this is usually a complex issue that is related to active disease, disease treatment, nutritional or metabolic causes, or kind of a combination of all of these things. So diagnostically, when I'm working with my patients around this issue, I often will rule out organic causes of fatigue, including checking for anemia or low blood counts, thyroid dysfunction, nutritional deficiencies, including vitamin D, vitamin B12, folic acid, and iron. And those are things that I often will repeat for my patients because, we don't want to miss something that's easily treatable and correctable. Unfortunately, many times those turn out to be normal, and we're left with a relatively unsatisfying conclusion that it has more to do with kind of the active treatment and sequelae of cancer treatment that are leaving our patients feeling fatigued. And in that case, we have to take kind of a multimodal approach to managing this condition, including taking frequent rest as needed and really learning to honor the body and not push ourselves, when there is that need for additional rest compared to what we might be used to as a baseline energy state. Optimizing sleep health is a big part of the work that I do with patients who are dealing with fatigue, because a lot of times it goes hand in hand with unrefreshing sleep or insomnia. Moderate regular exercise has a lot of data for supporting cancer fatigue, and I've included some studies there that you can reference if you'd like. There are Western medical treatments for this, including Ritalin or methylphenidate, and this is something that we do use in certain cases for patients who are really struggling with fatigue that interferes with daily quality of life. Acupuncture has also been shown to be helpful for fatigue, and I often refer my patients for this. And American ginseng is also a supplement that has been demonstrated in a randomized controlled trial, and I've included a graph result from the trial here. It has been shown to be quite helpful for cancer-related fatigue as compared to placebo over an 8-week period. So I'll show you, we can actually look at the 8-week time point here. So this basically is a demonstration of sort of energy levels And as you can see, among the individuals who took ginseng 1,000 milligrams twice a day, as compared to those who took placebo, or essentially a sugar pill, there was a significant improvement in energy levels among those who took the ginseng. So this is something that we utilize a lot with our patients who are struggling with this, this condition. And then last, I just want to touch on advanced care planning for a moment. And this is one of the ways that we can be helpful in your care and your life experience as well. I know many of you, well, I don't know, but some of you may be thinking, why are we talking about this when my disease is stable and I'm doing really well? And the reason is because, and I'll get into some of the data momentarily here, but the time to think about advanced care planning is really when you are doing well, because it's much better to be prepared for a number of reasons around these topics and these discussions, both for your own care as well as for the peace of mind of you and your loved ones, when you're doing well and when you have that gift of time, rather than when you're in the midst of a medical emergency, where thinking through these questions can be profoundly overwhelming. So what is advanced care planning? So in short, it's a process of learning about, communicating, and documenting your preferences regarding medical care in the event of a life-threatening emergency. There's a few important steps, and I've highlighted them here. The most important one is really to identify one or more loved ones who can serve as an emergency contact for you in the event that you're not able to speak for yourself. And this is typically known as a surrogate decision maker or a healthcare power of attorney. It's also important to clarify and articulate preferences regarding life-supporting care, including chest compressions, intubation, artificial nutrition, and some others. And finally, it's important to document these wishes in a legal document known as an advance directive, which can be shared with both your loved ones and your medical team, and can be turned to in the event that you're unable to actually speak for yourself. And here's an example of an advanced directive that's available through prepareforyourcare.org. And there are several different documents that are all considered to be legally viable. So there's a couple of reasons to think about a proactive advanced care planning, and I've already touched on this a bit. Number one, it's associated with improved satisfaction of both caregivers and patients. And it is associated with improvement in values-aligned care. So patients who proactively pursue advanced care planning and document their wishes are more likely to have those wishes honored at the end of life than those who do not. And I didn't include this stat here, but actually 70% of Americans do not proactively pursue advanced care planning, and it can often lead to care that isn't really desired or beneficial at the end of life. There's many additional resources here that I wanted to make sure that you're aware of, since we won't have time to dive too deeply into the topic today, including several wonderful workshops and kind of a wealth of resources through the UCSF Mary Center, which is affiliated with the Division of Palliative Medicine, and I've included the website for you here. The Prepare for Your Care website is a great place to actually find an advance directive. There's also the California Post website that you can check out. And then there's also some tools for thinking through how to approach advanced care planning. Many of my patients really love using the Go Wish cards to think about what's important to them and explore those topics for themselves and with their loved ones. And there's workshops that we offer on advanced care planning as well. And then there's also been a discussion already on advanced care planning with my colleague Redwing Kazar. She's one of our nurses, and this is really her whole area of focus and expertise. So I wanted to link you to that video as well so that you could explore that if you would like. And that is actually my last slide, and we have about 10 minutes for discussion. So I think we probably could stop the recording, Josh, and just